Relapse is a very common problem with myeloma. The majority of multiple myeloma patients, despite everything we have, will relapse. I think what's happened over time is the time frame has changed completely for both the transplant eligible as well as ineligible patients. On an average, your first remission is anywhere between 4 and 5 years now. And that would be the first time that a patient will relapse with their disease. And then what we are seeing now is patients are relapsing multiply, because even with your first relapse and your second relapse, you have pretty effective treatments available to our patients. And what we typically see in our practice now is patients having had 7 lines of treatment, 8 lines of treatment, and that's a good news story. You know, a few years back, we did not have those many lines of treatment. We do now, and that's part of the reason why our patients are living that much longer. So we've certainly made a big dent in how long patients live, and that they're living a whole lot better. And in the very refractory state, right now, it's usually after 3 and 4 lines of treatment, and on average after about 7 or 8, anywhere beyond 5 years of their treatment for their myeloma is where you find the true refractory multiple myeloma patients.
In addition to some of these clinical trials and the immunotherapies that are being tested, there's other options for patients who have advanced disease. One of the most looked after set of clinical trials are those that involve pomalidomide combinations. So we have pomalidomide, of course, with its track record in combination with dexamethasone, but I think more and more we're using it in combination with other agents. We had the Optimism clinical trial where pomalidomide was combined with bortezomib with a very high rate of response. It's a regimen we've used quite extensively in the clinic. In fact, I'll tell you, just yesterday I saw a patient in the clinic who we used this regimen 4 years ago. He's in a CR. He's doing great. This person who had a number of other medical problems with COPD was sent to hospice, came out of hospice. 2 years later, he's doing well and just with good disease control without therapy 4 years ago. Pomalidomide can also be combined with elotuzumab. We saw a recent clinical trial that was published in the New England Journal where they show a high level of activity. They talk about a response rate of close to 60%. Now this is also very exciting. Elotuzumab is a very well tolerated medication, and that is potentially another regimen we're going to be using in this patient population. Pomalidomide has been combined also in other settings in a small study with cyclophosphamide and older regimen. We have the combinations that include panobinostat. We haven't used a lot of that because of some of the toxicity, but there's some clinical trial data that would show it works in a different schedule and with some other combinations, including with carfilzomib. So I think that's another option for patients. But our first stance when we see someone who has advanced refractory multiple myeloma would be to do a very careful review of all the drugs they have received previously and then think about combinations we may be missing from those prior lines of therapy.
Approval of drugs for multiple myeloma is incredibly important because it opens up access to patients and it opens up availability of those drugs to patients. Now, the most recent approval of pomalidomide with the elotuzumab and dexamethasone, obviously it's a good thing for patients wherein it can be used in combination. Having said that, this, although it's defined as for very refractory patients, as I've mentioned earlier on, it does not include patients who've seen daratumumab. So in the real world, the data may not be exactly based on label, and that's something we always have to think about in myeloma. And I think this was true even when daratumumab got approved with the CASTOR and the POLLUX studies, because there's a reason why a lot of these approvals happen in Europe and not in the United States necessarily. That's because of access to drugs and what is available in those situations. And so that patient population is more reflective of that geography. I'm not saying that that drug combination cannot be used. It absolutely can be, but you have to temper the results of what you're going to get if your patient has been exposed to a whole bunch of other drugs. And that's why getting an approval is a good thing, but really, putting that data in the context of your patient and what your patient has had is going to be able to provide you with a more realistic expectation on what the data is going to look like in that particular patient.